Okay, hello. Now, I apologize. You will notice when you play the video lecture for this week that there are two recordings. This is the second. I got disrupted and it took a lot longer. So it's actually been like an hour since I stopped the other one. And um, I couldn't pause it for that long. So I had to just start another video. Also, one thing I recognize that I will be sending you an email about is I I realized that that CIHS posted the older version of the syllabus to the class material. So what you have is actually the older version. I will email you the newer version. It wasn't a problem, but it will be after this because we talk about autism next week, and the old version has a different. I think it has impulse control disorder. So I will make sure you have the newest version of the syllabus. I'm not sure how that happened. Okay, but let me pick up on where I left off here. I have my notes back up here. So we talked about schizoaffective, and as I talked about, schizoaffective is, in my opinion, one of the most disorganized, sort of extreme psychiatric conditions. I will say that whenever I've had a patient that I worked with who has kind of presented the most difficulties as far as understanding their symptomology, and when it hasn't involved them having brain damage of some sort, it has most often been schizoaffective disorder, just because, like I was saying before, schizoaffective disorder ends up kind of being like a mismatch of everything, of all the symptoms. They're all out there. Okay, so that's schizoaffective disorder. The next diagnosis I want to talk about is schizophreniform disorder. And um, really, that's a basically a form of schizophrenia that only lasts between 1 and 6 months. Um, Schizophrenia has some or most of the symptoms present for 6 months, not necessarily all the symptoms, but some or most for 6 months or more. Schizophreniform is 1 to 6 months. So it's a shorter version of schizophrenia. Now, um, that 1 to 6 months is actually noteworthy because there is yet another psychotic disorder diagnosis called brief psychotic disorder. And brief psychotic disorder is a month or less. Um, Now, brief psychotic disorder tends to be something that occurs immediately following a stressor. Um, some examples might be death of a family member. Um, and so basically, losing someone can result in the person having some sort of psychotic break that lasts for a month or less. And recovery tends to be very, very quick. Now, um, brief psychotic disorder, you have to be kind of careful of because let me just give you an example. I have worked with, I worked, as I talked before, in a lot of medical facilities, and I've worked with a lot of older individuals who have been married for 40, 50 years and their spouse dies. And they will insist that they see the person coming around and visiting them. You want to be very careful that you are not diagnosing something like that as psychosis. It could be a lot of things. Certainly spiritually, people would say that could be exactly what's happening. It could be a memory, if you want to go more on the, scientific side. It could be a memory. Certainly CIHS does a lot of research on, you know, consciousness after death. So there is, CIHS would certainly have a lot of uh, people working here and research that sort of allows for the possibility that someone may be seeing a loved one, you know, after they die. It's certainly a possibility. Brief psychotic disorder, general rule I follow. It's not anywhere in the uh, in the criteria, but general I follow is if the psychosis, if the hallucinations or the delusions that you're considering relate directly to the person that they lost, um, I would tend not to diagnose it as brief psychotic disorder. So if it has to do with them seeing the person or um or thinking the person is still there, feeling their ghost or their spirit around, I would be hesitant to diagnose that as um a brief psychotic disorder. But if they are having a hallucination that occurs following the death of a loved one, but it doesn't relate directly to the loved one, then that's more clearly brief psychotic disorder. Where you also see brief psychotic disorder, um, um, most, well, a common brief psychotic disorder is not common, but one of the most prevalent reasons it occurs is death of a loved one. Another is a natural disaster, earthquake, flood, where the person's life is kind of destroyed, um, all at the last minute. And I can't say I have solid research on this, but I can also say from everything I've read and heard about brief psychotic disorder, um, it tends to occur with stressors that have a very, very intense impact and act quickly. So, for instance, the loved one of 40 or 50 years who um, dies from cancer, where maybe, they've been dying, or Alzheimer's disease, where maybe they've been dying for like a year, that tends to less often lead to brief psychotic disorder than, say, the person having a massive heart attack and dying or getting hit by a bus. Something where they're alive 1 minute, next minute they're dead. Um, and so that's the stressor component to it. It's not just the loss, but it's the loss of everything was fine 1 second, now it's not. And so uh, that tends to be the type of stressor that most likely would lead to brief psychotic disorder. By the way, there is in the medical field, there is a form of brief psychotic disorder that is specifically associated um, with postpartum. So there is such a thing as a postpartum psychotic episode. Very rare, but it does happen that after the birth of a baby, um, an individual um, might have a psychotic break of sorts. Differing, by the way, and this, I don't want to take too much time on this um, because it doesn't, it's very, very rare. Postpartum depression is more rare. It's basically a very severe form of postpartum depression. So when we talked before how depression sometimes can have psychotic features associated with it, um, postpartum psychotic disorder, brief psychotic disorder, is sort of an extreme form of depression. And it's interesting to keep in mind that there's debate about, well, could this occur because of just because schizophrenia is at its very base a neurological disorder. So could this be occurring because the individual is sort of faced with this like uh, very immediate, very quick impact on their whole physiological system? Having a baby, all the being pregnant causes a considerable um, changes in all a woman's physiological makeup, and then having the baby does the same thing. So could it be that it's a neurological factor associated with the physiological impact of having a baby, or could it be somebody having a psychotic break who's sort of predisposed to have a psychotic break and is dealing with the immediate stress of having a baby? I mean, if you think about it, this whole idea of things are one way 1 second and then immediately they're another way. Having a baby would be a perfect example of that. Not necessarily, I mean, you would hope not in a bad way, but there certainly are a lot of negative stressors associated with now being responsible for this life that 2 seconds ago you were not responsible for. I mean, it was inside you, but it wasn't a separate life that you are now totally responsible for. So there's the question of could uh, postpartum psychotic disorder have to do with the neurological factors and more along the lines of the neurological aspects of schizophrenia, or could it be the immediate and very quick, intense stressor that sometimes leads this to happening? Interesting other category um, is what is called shared psychotic disorder. This is again very rare, but it's interesting to sort of keep in mind this whole aspect of psychotic disorders and how they develop. Um, is when one person develops hallucinations and delusions, and then somebody else uh, develops the same beliefs. Um, so now the difference is and why it's called shared psychotic disorder and not just a separate schizophrenia is the person what the person develops similar to this other person are the hallucinations and delusions. So they're married to someone with schizophrenia. That person believes has all the symptoms of schizophrenia, including their having a delusion that aliens are spying on them. Now, that would be schizophrenia. In the case of shared psychotic disorder, that would be when the spouse starts to also believe that aliens are spying on them, but doesn't have any other symptoms of schizophrenia. Um, so it is not that this is a case of two people who both have schizophrenia um, get married. And so you just have two individuals with schizophrenia. This would be two individuals are together. One has schizophrenia or some other form of psychotic disorder, one does not. But over the length of time that they spend with this person, they start to develop the same hallucinations and delusions that the other person develops. So they would be diagnosed with shared psychotic disorder. Okay. Uh, Now I know we talked last week specifically with some interest um, uh, delusional disorder. There's a diagnosis called delusional disorder, and really all delusional disorder is when the person has delusions but does not have any other symptoms of uh, schizophrenia. So it is when the person has delusions, uh, but there are no other symptoms of schizophrenia. And I'm looking up on my screen here because there's one other diagnosis I wanted to touch on, uh, that is called paraphrenia. Paraphrenia. And what that simply is paraphrenia is a form of schizophrenia that starts um, when the person's elderly. Um, Now, why that develops, how that comes about, um, is unclear. Um, it could be because there are also dementia with psychosis. So dementia can be diagnosed as having psychosis. Paraphrenia is when there's no sign of dementia. Dementia is specifically defined as um, uh, a decrease in the person's cognitive functioning from the previous. So dementia would require the person, if they were that along with the psychosis or the psychotic features, they also were losing their memory, losing their intellectual functioning, having worsening of their ability to understand things. Paraphrenia is when none of that is present. The person's mental status doesn't seem to have changed much, but they still are showing signs of schizophrenia. One of the one of the reasons I wanted to bring that up, but one is it's just interesting. Um, the other is where I first heard of paraphrenia was that it was associated with severe hearing loss. That the sort of theory behind it was the person starts, and also vision loss. I heard about with hearing loss, but it also could be vision loss. That the theory of it was that what happens was it's not a neurological fact because not a whole lot of neurological uh, factors that would explain paraphrenia. You know, there's nothing about neurological changes in old age that connect directly to schizophrenic symptoms. But what I have heard is that where it tends to occur most often is with individuals who are starting to lose their hearing and are starting to lose their vision. So basically, they are losing touch with reality, coinciding with their losing contact with the outside world. So their ability to have any sort of contact with what's going on around them because they can't hear and they can't see is leading them to have psychotic symptoms. So that's just an interesting example of how something like schizophrenia might develop. That sometimes you start to see symptoms of schizophrenia for individuals who are losing contact with reality, in part because they're actually losing contact with the real world. They cannot see, they cannot hear, and so they're functioning all inside their head. And so it's leading to delusions and hallucinations. It doesn't happen a lot. It tends to happen more with old age in the elderly, and often associated with this loss of uh, senses. Okay, so where I wanted to sort of touch base here at the end was sort of talking about okay, so we talked about the different types of psychotic disorders. Let's talk a little bit about well, where's this all come from? What is this? What are we talking about? So you've basically got with psychotic features, people developing hallucinations. By the way, I let me before I move on, I pulled up a couple other notes that I had. I talked about how hallucinations can be um, seeing things that aren't there, hearing things that aren't there. Hallucinations, I didn't bring this up before, can also be um, olfactory. People can taste or smell things that aren't really there, or tactile. So they can be auditory, visual, olfactory, or tactile, meaning how they're feeling things. Like bugs, feeling bugs crawling on their skin is a common tactile um, hallucination. And then, like I said, with delusions, I wanted to go through this definition of what a delusion is. False beliefs that don't go away even after they've been shown to be false. So, and certainly that can be up for debate as to whether, a lot of people believe things that someone else believes they have shown to be false. Um, Courtrooms are like that all the time. One lawyer tries to make a position and can't understand why the other person still believes something that they have shown to be false. Well, that's just a matter of that's an issue of opinion, but something that the person still believes after it's been very clearly shown to be false, that's a delusion. So, what tends to happen? Uh, what tends to happen with schizophrenia? Well, schizophrenia is, as we talked about, bipolar disorder, and we'll talk about with autism, is a neurological condition first and foremost. It doesn't mean that there's nothing a therapist can do to help, because um, the neurological condition is seen as being the precursor. The person has the potential to develop schizophrenia, but stressors in their life tend to be what trigger that whole set of symptomology. So, um, so it's a brain disorder, a neurological disorder, but stressors have a major role in it. Um, Tends to occur most often um, in late teens or early 20s. Can start to appear in early 30s, but the most likely tends to be late teens and early 20s. It is not clear if that is um, because of the neurological development and people are just more danger of things being caused at that point. So if it's part of the neurological development at that age, or if it's because some of the most um, noteworthy stressors that people face occur in early 20s. Schizophrenia, you hear very often about college students who first start to show schizophrenic signs when they're in college. Um, Early 20s, late 20s are where people get married and start to have families. They start to live more in, very often it's late teens, early 20s where people start to live more independently um, from their family. So now they're depending more on themselves. Um, so there are a lot of intense stressors that can occur in late teens or in early 20s. So the fact that schizophrenic symptoms tend to occur most often then could be related to that. I wanted to give you one term here, and I lost it from my notes here, so I apologize. I wanted to um, pull this up here. When we, and I know you read this came up in the book, but I wanted to give you one specific uh, glutamate, glutamate, um, is considered one of the most prominent neurotransmitters involved in the development of schizophrenia. So when we talk about things going on in the brain, impairment of glutamate is seen as something that often plays a role in the development of schizophrenia. And very often, when therapists are working with someone with a psychotic disorder, very often what you're focused on is helping them find effective ways of not letting stressors impact them so much, uh, so that there is less likelihood that they are going to have psychotic breaks because they are dealing better with stressors. All right. I think that's good for now. And I will see you on Thursday night. We'll see you then.